and welcome to today's session on pressure ulcers and the management of pressure ulcers. I'm Jen Letchford and I'm Tissue Viability Nurse Advisor with Coloplast. Today I'm hoping that this session is really going to help you to identify some of the challenges that you might be facing with pressure ulcers and how we can overcome those challenges. Today's session is purely educational and it is endorsed by the Tissue Viability Society. So some of the content that we'll be covering today will be looking at pressure ulcers and the impact that pressure ulcers can have not only on staff but on patients as well. Some of the factors that can be associated with increased risk of pressure damage, the importance of holistic assessment, pressure ulcer location and touching on our anatomy and physiology, the categorisation of pressure ulcers and how we can identify the category of an ulcer, and pressure ulcer prevention prevention and management really. So the learning objectives from today, you should be able to recognise the implications that it has not only on our patients but our wider health economy as well. Be able to understand and demonstrate the importance of holistic assessment, including our pressure ulcer risk assessment within that holistic assessment, and be aware of local and national guidance linked to pressure ulcers. So we're going to start by looking at the impact and implications associated with pressure ulcers. And actually, we see a huge number of pressure ulcers in the UK, which has a big financial impact. So, for example, pressure ulcers can account for up to 4% of the UK healthcare budget. So around £2 billion a year. And actually, latest research has shown that that figure has only increased. More than 200,000 people have chronic wounds, of which pressure ulcers are the single most costly within that category of chronic wounds. So a huge financial implication for the NHS and for our services. It also has a significant impact on our patients and can lead to really severe disability or amputation, possibly be life-threatening. If a patient has pressure damage that results in an infection and sepsis, it could be life-threatening. Osteomyelitis, so an infection of the bone, or prolonged stay in hospital or enforced bed rest, for example, if we're trying to offload pressure from a certain area. So it can have quite a significant impact. So we'll have a look at some of the factors that might be causing pressure damage and how we can possibly overcome some of those factors. But starting off, what is a pressure ulcer? A pressure ulcer is localised damage to the skin or to the underlying soft tissues, and the injury is normally over a bony prominence or can be related to a medical device. It can happen at any time and to any person, but it can be present on intact skin or as an open wound. It's likely to be painful for our patient and is going to result from an intense or prolonged period of pressure over a bony prominence. And that may be in combination with shear or shearing forces. And we'll come on to that in a little more detail a bit later on. So I'd like you to have a look at this image on the screen at the moment, and the red dots highlight the typical areas of pressure if somebody is laying flat on their back in a hospital bed, for example. We're going to zoom in here and just have a bit of a closer look at what a normal blood flow can look like. And you can see here that there's a good capillary exchange of blood and no significant problem. The effect that pressure then has is shown in the image here, and it's squashing that capillary from the external force of pressure over the bony prominence. So you can see here how actually that would then start to, over a prolonged period of time, cause significant damage to those structures of those capillaries. What we can do is try to prevent that from happening with use of pressure relieving equipment. So an airflow mattress, for example, which is what the image on the screen is trying to replicate. And the idea of that is that the pressure relief is given from every sort of third or fourth cell, depending on which equipment you have, to relieve that pressure. But it doesn't prevent that altogether. The pressure is still there, it's just relieved for a period of time. So actually, the pressure relieving equipment that we can have will help, but it won't eliminate the problem completely. Repositioning is another thing that we need to be very conscious of, and we can cause damage through shearing forces by repositioning somebody. And you can see here the arrows on the screen, the red arrows, indicating that actually our bony structure has remained in the same position and that force is coming down. But actually, by lifting just the back of somebody's bed up, for example, we're creating a shearing force and pushing the skin in the opposite direction. So we've already established that we can have a problem with the capillary and restricted blood flow if we have a pressure. But if we have pressure plus a shearing force, we're only extending the potential of damage. And we go on to look at that here and that shearing force. And you can see what I mean. There's a shift in the way that the capillaries are sitting, as well as that pressure, which we've already established will be there from the external force. So what we need to be looking at doing is positioning somebody in the correct way, using a knee break, for example, and trying to relieve that pressure, stopping that skin from moving in the opposite direction to a bony prominence by supporting somebody's position to prevent that from happening. And a knee break is ideal for this, or it could be a foam wedge that you're using, or potentially even a pillow or towel rolled up if necessary, if you have nothing else. But it's something that we should be looking at when we're thinking about the repositioning of our patients. So again, the prevention in a seated position, if we're doing this properly, and if we're using knee breaks and we're ensuring that we're appropriately seating a patient, we're reducing that risk of the shearing force. We still have the force of pressure from the external surface in the bony prominence, but we're eliminating the shearing force, so we're reducing the potential for damage as much as possible. We're then going to move on to look at our holistic assessment and our pressure ulcer risk assessments within that. There are a whole multitude of things that we need to take into account when we're thinking about pressure damage and the prevention and treatment of pressure damage. And the key thing to the heart of this really is our holistic assessment of our patient. And built within that, we then have these subcategories, if you like, of our risk assessment, the pressure ulcer categorization, any pressure relieving surfaces or devices that we might be using, taking into account the overall skin condition of a patient. So if somebody's skin is dry, for example, it's more prone to break down than it would be if it were kept supple with an emollient. We then need to think about our management of a wound if somebody has developed a wound, and what we can do to create an optimum healing environment for that person and that wound. But as well as that, we need to think about the prevention strategies to stop this from occurring again in the future, or to prevent further breakdown of other areas. So a whole multitude of things that we need to consider. And to help us consider this and these things, we have a couple of national campaigns which have been around now for a few years. One of them is the Asking campaign, so where we're assessing risk, looking at the skin assessment and skincare regimes, the surface in which somebody is sitting on or using or laying on, talking about keeping them moving as much as possible to try and prevent immobility, preventing and reducing the risk of pressure damage occurring. Incontinence and the role that can play when we're looking at pressure damage. And we'll go on to that in a little more detail as well a bit later on. nutrition. Somebody's nutritional intake can really impact wound healing and can also impact the overall skin condition. So we need to be thinking about that. Also giving the patient as much information as we can. That could be to the patient themselves, it could be to an informal carer, it could be to a paid carer, but to try and give as much information in order to educate the people that we're looking after, to try and help them to help themselves in preventing pressure damage from occurring. We then move on to a different campaign, which is the Reactor Red Campaign. And you may have seen this on our national or international stop pressure days in November. And this really was implemented originally to nursing and residential homes, mainly residential is where it started. And that was looking at the early intervention and early warning signs of pressure damage. And it's something that actually all of us can do and all of us can take forward in our practice. And it's something we should be doing as part of our holistic assessment of a patient and our skin checks when we're admitting a patient to a caseload, for example. So it's reacting to red, having a look, making sure that there aren't any red areas over a bony prominence. And if there are, then doing something about that and trying to prevent that further breakdown of skin. So who's at risk of developing pressure damage and pressure ulcers? Well, actually anybody is. Of any age, of any nationality, there is a potential there for you to develop a pressure ulcer. I know myself that I've had pressure damage in the past from ill-fitting shoes. Going out, getting a blister from a shoe on my heel over that bony prominence where I've had the friction and shearing forces from the external pressure of the shoe, creating a blister, a serous-filled fluid blister. That's actually category 2 pressure damage. So it can happen to anybody. We're going to look at now some of the intrinsic factors first, so some of the things that can be associated with an increased risk of developing pressure damage. And they can be things such as previous history of an ulcer, any circulatory abnormalities or problems, vascular disease. If somebody's acutely unwell and has a reduced level of consciousness, for example, it could be that they've had a fall at home and a long lie on a hard floor. They're at significant high risk there of developing pressure damage. Or people at the extremes of age, and that's because we know that there are skin changes as people get older, for example. The skin starts to diminish its natural functions, and actually that can have an impact on and increase a risk of pressure damage. We then look at some of the extrinsic factors. So somebody's reduced mobility or complete immobility. Moving and handling aids and techniques, are they appropriate or are they causing problem? Somebody being dragged up a bed, for example, rather than a slide sheet being used, it's going to create more of that shearing force, which in turn is going to put the person at higher risk of developing pressure damage. Length of surgical procedures. I've already mentioned if somebody were on the floor with a long lie, for example, after a fall, but actually the same goes if they're having a surgical procedure and they're on a hard trolley or theatre table for any significant length of time. Then we come on to devices, and actually we need to be thinking about all types of devices, whether that's a catheter, oxygen tubing or a mask, any even medical masks that we're using currently because of the COVID situation. Is it a hard edge to a mask? Is that going to be causing a problem for some people over the bridge of the nose maybe? All things that we should take into account that might put somebody at higher risk of developing pressure damage. And to help us identify the risk, we have a number of assessment tools available to us. And you may or may not be familiar with all of these, or some of them, maybe just the one that you're using in your local area. But there are a number of tools available. Probably the most commonly used is the Waterlow scale or the Braden scale. The Purpose T tool is a more recently developed tool. And the Norton scale we don't see as much anymore. But the thing that all of these scales have in common is that they give us, they identify or help us to identify whether somebody is at risk of pressure damage and how significant that risk is. So it could be that they give us a number, or it could be that the result of the assessment, once we've completed it, gives us a colour or colour coding, like the Purpose T tool would, for example, of that red, amber, green, to highlight the level of risk that somebody has. If somebody has a level of risk, it's identified here, and we should be documenting that in our clinical notes. But then what do we do with it? These assessment tools are just that. They're a tool. It's not a rule. So we need to act on our findings. And actually, it's really important that we do this to try and prevent further breakdown. If we recognise that somebody is at risk or at high risk of developing pressure damage, then we need to identify what equipment they might need to try and reduce that level of risk. It's at this point that we really need to be trying to put in prevention measures. So again, it's a tool, not a rule, and it should form part of our overall holistic assessment. So pressure ulcer location is what we're going to focus in on next. And this is really important. So we may be saying in our notes, somebody has pressure damage on their bottom. There are multiple areas on the bottom that have bony prominences that we need to be able to identify the difference. If we can identify the exact anatomical location of a pressure ulcer, then we have more chance of establishing why it's happened in the first place, what the cause was, and how we can then prevent, treat, and manage that pressure ulcer. For example, you know, on the bottom, going back to the bottom, you have the sacral area, and you've got the ischial tuberosities. So very different areas, and although we may want to try and manage these areas and offload somebody and the pressure that somebody is experiencing, we need to identify where exactly the pressure is so that we can think about appropriate ways to offload the pressure from that area. So we've got a list here of some of the at-risk areas, and I'm not going to go through each and every one of them, but I mentioned the ischial tuberosities. For those of you that aren't aware of what those are, it's your seating bones. So whilst you're listening to me now, if you just slide your hands in underneath your bottom and you gently rock from side to side, you should be able to feel those bones that you're actually sitting on. And you can see that if somebody is in a seated position for any extensive period of time, that actually that could be quite uncomfortable. And we might notice it and move around quite freely. But if you've got somebody who is not able to move themselves around, that's wheelchair bound, for example, and sitting on those bones for an extended period of time, not able to move themselves when they become uncomfortable, they're likely to develop pressure damage in that area. We then have the occiput on this list, which is actually the back of somebody's head, and I have a good image on the next slide, which I shall show you in a minute. The nasus, so around the nose and the bridge of the nose. The pinna, which is the ear, and again I've got some images for some of these things a bit later on. So the at-risk areas, I would say try and familiarise yourself with these areas. These are the most commonly seen areas of pressure damage. And it's a good idea to understand the exact anatomical location so that you can be clearly documenting that in your notes. As well as these areas, we also have to take into account those areas which are linked to a medical device. And I say this because that can be things such as a catheter. Now, I've seen a couple of gentlemen with category 4 pressure damage because of a catheter and the weight of a catheter, and the tubing has caused significant damage to them. So we need to take into account all of these things when we are completing our head to toe assessment and looking at level of risk. So some of the further examples that I have mentioned on the previous slide. medical devices, and you can see here that the top left image of the baby has actually got pressure damage on her ear, so on the pinna there, on the outer part of the ear. Then we have the occiput, which is the back of the head, in the centre image at the top. And then I'm going to just move on to the right-hand image on the top row, which is the malleolus, so the ankle bone, the outer malleolus in this case. So there are various things that we need to consider, and examples of pressure damage, that you can see in these images are unfortunately quite common. And we just need to bear that in mind and make sure that we are documenting correctly and that we know the anatomical location ourselves, so that we can then start to pinpoint what the causative factors have been, or contributing factors have been. If we can remove those contributing factors, then we give this wound the best chance of healing. So if we now move on to look at the different categories, and this is the thing that people find, or seem to find most challenging, is being able to identify the different categories of pressure ulcer and feeling comfortable with doing that. So we're going to go through each category in a little bit more depth, but we have 6 categories that we look at, and that's category 1 to 4. We then have unstageable pressure damage and deep tissue injury. So we're going to start by looking at category 1 pressure damage, and that's that non-blanching erythema of fair and pale skin. So when you're pressing down over a bony prominence, there's a red area. If you press down and release your finger and it doesn't blanch, so it doesn't go white and then come back as a pinky red colour, if it just remains red, that would be non-blanching erythema. And actually, you may find that your patient is saying that this is quite painful. They're uncomfortable in that area. There could be presence of soft or cool, firm tissue in comparison to the adjacent tissues. Sensation is going to be different for somebody over that area because the damage of those capillaries and things has already started to take place. So the damage is already there at this point. We need to try and prevent that at that stage from getting any worse. What we shouldn't be seeing here with category 1 pressure damage is a purple or maroon discoloration. That would actually indicate deep tissue injury rather than category 1 pressure damage. And I have a very good image here to identify category 1 damage, as well as some moisture damage. So I'm just going to use the mouse here to highlight this area here over the ischial tuberosity, that seating bone that I've been talking about. And you can see that there's a slightly darker red area. I'll move the mouse out of the way now so that you can actually have a look and see. But that's category 1 pressure damage. I'm then just going to highlight this further red area that you're seeing across both buttocks with a sort of butterfly or mirror image effect on each side. That's actually moisture damage. So this image, you can see both pressure and moisture associated skin damage. And we'll come on more into the moisture associated skin damage a bit later on. Category 1 pressure ulcers in darkly pigmented skin can present slightly differently, and it may be that those subtle changes of skin differences and blanching you're not able to see visually. So you might have to rely on your assessment with your patient and talking to your patient. Have they got any pain over this bony prominence? Is it causing them a problem? Is there a temperature difference in the skin in comparison to the surrounding skins and tissues? Is there any edema or swelling present? Sometimes we can identify that there is damage just from a slight edema presence. So take everything into account that you're seeing. Make sure that you're visually inspecting the area and also using touch, because that can really help, just to gently touch the area and feel any differences in temperature, for example. But rely on your patient as well, who's telling you, if they are telling you they're in pain, there's a reason for that pain. You can see in this image here that there is some slight discoloration. That is actually category 1 pressure damage, but it presents in a slightly different way to what it would on paler skin in that very red prominent area. category 2 pressure ulcers and this partial thickness skin loss. It can present as a very shallow open wound, just losing that very top layer of skin. It can be a red or pink wound bed, and there's not any slough presence in these types of wounds normally, or it could present as an intact serum filled blister, as I mentioned earlier on. You shouldn't be able to see any adipose or fatty tissue, and there should be no underlying structures visible either. So I'll show you another image here of that superficial skin loss, that typical category 2, and you can see that there's no real depth to this wound, but just that top layer of skin lost, and that would be typical of a category 2 pressure ulcer. Sometimes category 2 pressure ulcers are mistaken for other types of skin damage, and I have just briefly touched on moisture associated skin damage in the previous slide when I showed you the image, but what we most commonly see is the Incontinence-Associated Dermatitis, and that can be mistaken for category 2 pressure damage. So we just need to bear in mind what we're actually looking at, whether it's over a bony prominence or not, and if it's not over a bony prominence, is it true pressure or pressure related to a device, or could it be that we're looking at one of these other potential causes? So you can see here the image on the left is Incontinence-Associated Dermatitis, and you've got that sort of mirror image, irregular edges, and excoriation really to that skin. The middle image here is Intratype Dermatitis. That's a difficult one to try and say. But this is under a fold of a skin, and this is actually just underneath the breast. And you can see there, again, that excoriation from sweat and moisture. Again, it could be identified as pressure damage to somebody who doesn't or isn't familiar with what pressure damage really is. Then skin tears. Sometimes I've seen documented that a skin tear is documented as category 2 pressure damage. Well, actually, we just need to be really thinking and looking at our assessment of this patient and what the presenting factors are, and establishing whether it is true pressure or whether the cause is because of another reason. So that then brings me back to pressure damage and category 3, full thickness skin loss. So that full thickness tissue loss, where the adipose tissue, those fatty tissues may be present, but you definitely won't be seeing bone, tendon or muscle exposure in these category 3 full thickness wounds. You might have some granulation tissue, and there may be rolled edges to the wound. Depending on how long the wound has been there, you know, the more chronic a wound is, the longer it's been there, the more likely the edges of the wound will be rolled. Any slough or eschar that might be present, so the devitalised tissue that you might see in that wound bed, and there could potentially be some undermining or tunnelling with this type of wound as well. The depth of the wound will actually vary depending on the anatomical location. And this is why I've really spoken about the importance of the anatomical location. As you can imagine, a pressure damage over the bridge of your nose from a mask or medical device, there's not as much tissue or thickness of tissue there as there is, say, on your ischial tuberosity, on your seating bone. So you're going to get to that full thickness skin loss far quicker over the nose than you would on your ischial tuberosity. So the depth of tissue loss can vary depending on that location. Again, a really good image, clear image of a category 3 full thickness tissue loss, and this has got those slightly rolled edges. You may even in this wound have some slight undermining possibly under this lip or under this rolled edge here. So again, something to just be aware of. Then we move on to our category 4 pressure ulcer and that full thickness skin and tissue loss. And this is where you may well see exposure of bone, muscle, tendon, ligament, cartilage in your wound bed. And these people with these types of wounds are at very high risk of developing infection and potential for developing osteomyelitis, so infection of the bone. And actually there can be some undermining and tunnelling with these wounds as well. And these can be really challenging wounds to try and heal. We want to try and prevent people getting to this level of tissue loss as much as we possibly can. And you can see in the image here, it might look sloughy. If you're not very experienced with wound care, then you might think that this wound is just very sloughy looking. Well, actually, if we look slightly closer here, you can see almost these lines, these strips running across the wound bed. And actually, that's because this is tendon exposure that you're seeing, not just a sloughy wound bed. So this would be category 4 damage. We then come on to those where the depth is unknown, and it can be unknown because we have that thick plug of eschar or slough, and we just aren't able to see the depth of that wound until we would remove that eschar and slough. So if you have a wound and you have some damage there, but you're not sure of the depth because you can't see the wound bed itself, then that would be an unstageable pressure ulcer. So it's quite often blocked by, as I say, slough or eschar, that devitalised tissue. We would have to monitor this type of wound and try to debride, if it were appropriate to debride, to get that clean wound bed so that we can really see and establish the category of the ulcer. It's likely to be at this point a category 3 or 4 pressure ulcer that we're seeing. You can see here on this image that although we can see pink granular tissue to the edge of the wound, we have this thick plug of slough in the centre of the wound. That's stopping us from seeing the true depth of the core of that wound, which means that actually this is an unstageable pressure ulcer. And that's how we should be documenting this until we can remove this plug of slough and identify the true depth, whether that's down to bone and those full thickness tissue loss, or whether it's a category 3 partial thickness tissue loss. Then we have our deep tissue injury. And our deep tissue injury can present as that mushy or boggy type feeling tissue that's quite dark in appearance, or blood-filled blister, that purple or maroon colour, that bruising almost. This would be our deep tissue injury. Again, the depth of this is unknown. We know there's damage already done at this point, but we don't know the extent of the damage. Sometimes these deep tissue injuries can resolve themselves if we can eliminate the pressure, and they can heal without actually opening up. However, they do or may rapidly evolve, and the tissue will deteriorate and break down quite quickly to leave you with an open wound. And actually we can see here the start of a breakdown of a deep tissue injury. You've got this slight open area, but the damage is quite extensive and has already been done to these purple and maroon discoloured tissues that we can see. So the evolution of a deep tissue injury, and an example of this would be, as it states here, day 1, this very deep purple maroon appearance of the skin, but it's intact. By day 3, this has started to deteriorate, and we can see the break in the skin, and the skin is breaking down. But again, this isn't that this wound is getting worse at this point, it's that the damage has already been done and it's just evolving and almost bringing itself to its true colours, if you like. It's bringing itself to light as to how bad the damage and the extent of the damage actually is. On day 1, you may or may not have noticed the damage as well in the natal cleft here. Day 3, you can't really see that damage in the image. But again, it's deep tissue damage, and you can see that more clearly on day 10, where again it's evolved and it's starting to evolve and show its true colours, if you like, and the extent of that damage. But by day 10 here, you can see quite a significant difference in this damage and how the tissues are actually really starting to break down. So we do need to keep an eye on these images, on these patients, and reassess frequently. So moisture-associated skin damage. I've touched on it briefly throughout the presentation, and quite often it's caused by incontinence-associated dermatitis. So that constant exposure to urine or fecal matter, or possibly even sweat that somebody might experience, and it really can cause skin damage. It's that loss of the epidermis, so the skin might appear macerated, red, broken, painful, that kissing type effect or butterfly effect, as I've mentioned already, and irregular edges to the wounds. You shouldn't be able to see any slough or underlying structures with moisture-associated skin damage, but it is something that we should bear in mind when we're assessing a patient. Again, there's absolutely no necrosis when we're looking at moisture-associated skin damage. So it is just that very superficial skin loss, that loss of the epidermis, where it's quite red and angry looking and excoriated because of the constant exposure to that moisture, whether that's through urine, fecal matter or sweat. Really good image here, and you can see just the irregular shape. Again, it's on somebody's buttocks, but you can see the irregularity of the shape. There's no defined area over a bony prominence, and you can see some maceration at the edges of this part, and actually it looks quite wet to look at this area. So some of the key risk factors for incontinence-associated dermatitis, the intrinsic factors, is actually somebody to have incontinence-associated dermatitis needs to be incontinent of some sort, whether that's doubly incontinent or just urinary or fecal incontinence. But they will suffer with frequent episodes of incontinence to cause this sort of level of damage that you can see in the image here. And that's then having an impact on the overall skin condition and the poor skin condition, where actually we start to lose the pH balance and it starts to really affect that and cause this excoriation. We need to be taking into account somebody's nutritional status, and if they are on any medications or immunosuppressants that might be causing any increased risk, for example, or if somebody's critically ill and are potentially going to be laying in a bed, do we need to manage that incontinence in another way? We then look at the extrinsic factors. So the type of cleansing products that we're using on somebody. I've mentioned the pH balance of the skin. If we're using very harsh chemical sort of based products, then that again may be having an impact on the person's overall skin condition, which can increase the risk when it comes to incontinence-associated dermatitis. The person might not be able to clean themselves. They might have limited dexterity. They may have problems with mobility and getting to a bathroom, for example. So they may need some support and help to try and regularly cleanse the area and dry the area. Poor manual handling, again, with increased friction and shear, can cause higher risk level of damage to this area. So all things that we should be considering. Moisture-associated skin damages and the differences between that and pressure ulcers. So with pressure ulcers, we need to be looking at where the wound is. Is it over that bony prominence? What's the cause of it? Is it because of shearing forces as well as external pressure? And with moisture, we need to be thinking about, is the area wet? Why is it wet? What sort of moisture is causing this damage? Then location. And again, I've spoken a number of times now throughout this presentation about the anatomical location of the damage. Whether that's pressure or moisture, we really need to be identifying that. If it's directly over a bony prominence and is in one defined area, then it's likely to be pressure. If it's moisture and it's on a sacrum or perineum or around a stoma or wound edge, then we're not necessarily looking for that being over a bony prominence. It also won't have a defined wound. It will have irregular edges and there won't be any depth to those type of wounds. The depth to pressure ulcer will vary depending on the extent of the damage, as we've looked at today with the categories. The shape as well of pressure ulcers have very defined edges, often circular, or they could be irregular in shape, but not in the same way as you would find that kissing ulcer or moisture damage. With pressure ulcers, you may have some necrosis or devitalised tissue present, but you won't have necrosis with moisture-associated skin damage. With your pressure ulcer and the colour of the wound bed, or what you're seeing in the wound bed, you may have some slough, necrosis, non-blanching erythema, but with moisture-associated skin damage, it's likely to be red, pink, excoriation, or that white macerated tissue. So there are some distinct differences to help us identify the difference between pressure and moisture. So skincare, what can we do to try and prevent any breakdown in our skin? We can be cleansing skin with a pH balanced cleanser, and that will help the body's natural acid mantle to maintain itself. We can consider using moisturisers to hydrate skin. As we already know, if the skin is drier, then it can cause higher risk of damage. We can protect the skin from exposure to urine, stools and faecal matter by using barrier products if it's appropriate after our assessment. We may also, in worst cases and worst case scenarios, have to think about the use of urinary catheters or fecal containment devices on very high risk individuals. And this is where it really then comes back again to our holistic assessment of our patient and looking at every patient as an individual and the risk associated with these things for them. So more prevention, what can we do? Well, skin assessment and the frequency of our assessment. Really, if we're having a patient come to an acute area, so admitted to hospital or into a community hospital, for example, we should be completing our head to toe skin assessment as recommended by the European Pressure Ulcer Advisory Panel within 8 hours of admission. We should then also be completing it as part of every risk assessment that we do. It needs to be ongoing. This can't be something that we only do once. So it will be based on your clinical setting and where you are. If you're seeing that patient, for example, as a community patient and you're seeing them once a week and you're assessing them once a week, then you would be completing your skin assessment as well once a week. If you're going to discharge a patient from your caseload, whether that's in a hospital setting again or whether that's in the community, we should be completing a skin assessment prior to discharging. We need to ensure that this person has no problems that are linked to their skin moving forward, that we're expecting them to manage themselves. We need to make sure that actually there is no damage before we discharge them from our care. So we did touch on this when we were in looking at the categories today of pressure damage, but the erythema in darkly pigmented skin can sometimes be difficult to recognise, and we don't have that visible blanch response. So we do need to examine the person's skin for any changes and changes in the consistency of tissue, or speak to our patient, our patients can really help us and guide us with identifying any potential problems or causes. So make sure that you are including your patients in your discussions around whether they are experiencing pain, and getting them to identify the location of that pain for you. We then come on to pressure relieving devices and pressure reducing equipment, and there's a whole multitude of equipment available to us, and that will vary across area to area within the NHS. So we need to be thinking not only just about mattresses that we might put somebody on, whether that's a static foam mattress, whether that's a alternating air mattress, or whether we're looking at cushions. And if somebody is wheelchair bound, for example, do we have a cushion for them? Is it suitable for use in their wheelchair? Have they maybe had some pressure mapping done? We have wonderful devices available to us now. Most wheelchair services would have these devices to be able to map where somebody's most at-risk areas of pressure are when they're in a seated position. So have we done that? Have we sent them for that assessment and identified the best equipment for that person? When we're choosing the equipment and choosing the devices that we're supplying to patients, we really need to be mindful of their wishes as well, and whether they're going to use the equipment. It's all very well us providing an all singing, all dancing airflow mattress, but if somebody's not going to use that and they're not willing to use that, then it's not going to help them. So we need to get our patient on board with the decisions and have them take part in making those decisions about the equipment that they're willing to use. So again, just as a bit of a recap on this one, making our patient aware of the decisions and the risk factors that are included, whether they have any existing conditions that we need to consider. So if they've had previous pressure damage, which is going to put them at higher risk, we need to discuss that with our patient and take that into consideration when we are choosing which equipment is relevant for this person. The patient's body weight and body shape. Have we got equipment that's suitable for their body weight? Do they have a very high BMI? In which case, will our equipment support and still provide that pressure relief that we're hoping it will? Take into account somebody's body shape as well, because it might be that we need specialist services and occupational therapists involved in order to help support some of the equipment choices. And that could be with different types of pillows and support pillows and things like that. So each individual person should be assessed holistically and on a one-to-one basis. There's no one size fits all with pressure relieving equipment, unfortunately. So we need to familiarise ourselves with what's available to us and ensure that our patient is accepting of the equipment and comfortable with the equipment and is aware how to use the equipment. And these are all things that we should consider when we're choosing which equipment is suitable for somebody. We also need to think about repositioning techniques. How are we repositioning somebody? Are they sitting for an extended period of time? Do we need to be able to get them to think about maybe moving from a wheelchair, for example, back to a bed to offload some pressure at various stages throughout the day? If it's somebody that we're managing in bed, we need to consider 30-degree tilts and possibly a turns chart. We need to use manual handling aids that are appropriate. Trying not to leave manual handling aids in situ. So if we have a sling from a hoist, for example, if it's not an in situ sling, then it should be removed from underneath somebody. And that can be because it has hard plastic clips and things on it, which again, if that's sat underneath a bony prominence, it's going to increase that risk of pressure. So we need to be mindful of those things and look at the various techniques that we have available to us to be able to reposition. When we look at heel ulcers, which actually are unfortunately quite common, and it's one of the most severe types of pressure damage that we see. They tend to be, the most severe types tend to be on the sacrum or on the heels. And actually, we can completely remove this pressure from the person's heels. We can use cushions, we can use support surfaces to completely remove that pressure, to give this heel wound or ulcer the best possible chance of healing. So again, take that into account when you're assessing your patient. Make sure that if they're wearing shoes at any point, that the shoes are well fitted. Ill-fitting shoes can cause significant damage to people's heels and various other parts of their foot. We've talked about incontinence today and the risk factors associated with incontinence. So actually, we need to ensure that patients have appropriate tools to use if they need them, such as a urinary bottle, or if they need a barrier cream or film protectant to an area on their sacrum maybe, or in their natal cleft, to try and prevent that breakdown of skin damage. Somebody might need more frequent visits from a carer to change their pad if they're unable to do that themselves. Or we may, in the worst cases, need to consider catheters or fecal management systems to try and prevent that further skin breakdown. So again, prevention is better than trying to treat. So we need to try and identify these risk factors at the earliest possible stage in our holistic assessment in order to put those preventative measures there to stop this from happening. Nutrition, another real helper when it comes to prevention of pressure ulcers. We need to ensure that somebody is getting the right nutritional intake and that they are eating and drinking well enough to support their body and their bodily functions. So we need to check what their nutritional status is on admission, and we again have nutritional assessment tools to help us and support us with this. Individuals with a pressure ulcer, or those that are at high risk of a pressure ulcer, should have an intake of 30 to 35 calories per kilogram per day, with 1.25 to 1.5 grams of protein per kilogram of body weight per day. So that's actually slightly higher than the average person would need. So again, all things that we should be taking into account when we're looking at somebody's nutritional status. I've mentioned already that we have these screening tools, risk assessment tools. The MUST tool is probably one of the most commonly used, and it can be a real identifier and support as part of our holistic assessment of our patient and help us to identify any at-risk patients. So patients at risk of malnutrition will also be at higher risk of developing pressure damage, or they may have existing pressure damage. So, you know, again, another tool that we're able to use to help us in our overall holistic assessment of a patient. Back in June of 2018, we saw the NHS Improvements team come up with an update around pressure damage. And actually they identified then that all category 2 pressure ulcers and above should be reported. And that includes your deep tissue injury and unstageable pressure ulcers. So you should have a reporting system available to you, and you should now hopefully be confident in categorising pressure ulcers after today's session. So you would know those ulcers that would need reporting. Moisture associated skin damage should also be reported and counted in addition to pressure ulcers. So if you are identifying that somebody has MASD, then again, that should be reported and highlighted that that person has this moisture associated skin damage. Device-related damage should be highlighted as device-related pressure damage in your reporting system. So if you don't have a drop-down box for that, then you can fill that in the data entry boxes that you are filling in. So you should always try and give as much information as possible on these DATEX reports, or whichever reporting system you use. You should be giving as much detail as possible about why that damage has developed and what the cause of that damage is suspected to be. We're also no longer using the terms avoidable and unavoidable. Really, we shouldn't be seeing any pressure damage, but if we are seeing that, then we need to be identifying the cause and getting to the root cause and documenting around that. But we shouldn't be using the term avoidable or unavoidable. For those of you who remember the 72-hour rule, that no longer exists, so I'm actually not going to go into any detail on that. What we should be looking at is, when we're taking on a patient onto our caseload, is the term pressure ulcer present on admission, or POA. That is a term that will be used when we're looking at pressure ulcers, and actually this is where it's key to complete our holistic assessment and our skin assessment as soon as possible when somebody comes onto our caseload. And that's because we're trying to identify if somebody is coming onto our caseload with already existing pressure damage, and then we can establish whether that's happened in somebody else's care or in their own care if they're self-managing at home, versus if it's developed in our care. So we can keep an eye, and we can start to build a picture of what's happening, and we can start to identify trends as well through this. Then end-of-life skin changes and skin failure, we used to identify as Kennedy ulcers, but actually we no longer look at these as Kennedy ulcers. These ulcers should be reported and investigated in the same way that any other pressure ulcer is reported and identified. So I'd like to just thank you for joining me for today's session. I hope you found it useful. We have a whole list of references available if you would like to have a further look at any of this information from today's session. And if you have any questions relating to today's session, then please feel free to reach out to your local Coloplast representative, who will happily support you. Thank you.